All set? Thank you very much. It's about time. Should I give it a minute to start on 4 maybe? See if everybody wants to show up. All right. I see some familiar faces as well. Some colleagues and superiors and patients. I hope this will be beneficial to all. And honestly, I'll leave a decent amount for questions at the end. So if you have anything, you're more than welcome to write down. If you already wrote down some questions, I'll be happy to take those at the end as well. I want to make sure we get as much information to you as possible. All right. All right. So I welcome everyone to our lecture today about advances in shoulder and elbow surgery. My name is Mohammad Al Sawaf. I'm a shoulder and elbow specialist here at Frederick South. I've been working here for the past 8 years or so. It's been such a pleasure working with a good team. It's such a good pleasure to be able to talk to the community at large at some of the advances in shoulder and elbow surgery, about services and care that we can deliver here at home. We're pretty well balanced with the department that we have here at Frederick South, with quite strong represented specialties, including hip and knee arthroplasty with Dr. Benzav here, trauma care, arthroscopic care, whether it's for the hip, shoulder, elbow, wrist, knee. We have pretty strong representation for sports medicine, spine specialty as well. So I think it's a really well-rounded group. But the question is, what differentiates shoulder and elbow specialty? I think it's pretty unique in that it covers a single joint, the upper extremity, or 2 joints here, in all respects. If you're talking about joint replacement for the shoulder and the elbow, that is well covered, and we will talk about that. If we're talking about sports injuries to the shoulder and elbow, that is pretty well covered. We will discuss that as well. If someone comes into the emergency room with trauma and fractures to the collarbone, to their shoulder, to their elbow, we take care of those bone injuries and ligament injuries. Pretty strong focus on arthroscopic surgery. One of the strongest specialties and skills within the upper extremity is that a lot of the procedures can be done through a minimally invasive fashion. And last but not least, there's also a strong focus on nerve surgery. There's a lot of releases that go to the carpal tunnel, to the cubital tunnel, some of the other nerves that pass through the countryside as well. So a lot of stuff that gets to be done within that specialty. And that differentiates shoulder and elbow from specialties that focus more on a particular type of procedures, like hip and knee replacement, or a particular set of injuries like sports medicine. It's all encompassing within one anatomical area. The work that I do is really not just the work that I do myself. There's a lot of dependence on a team approach. I wouldn't be able to do what I do if it wasn't for my nurse Kate, for my physician assistant Liz, for my medical assistant Jacqueline. There's a strong help from people that I have in the OR, from the OR manager, from the nurses and the techs and the x-ray techs that really make it all happen. We get to be fortunate to be at the front line of seeing the patient happy with the results, but I would be remiss if I do not credit all these people with their contribution as well. The second thing that I try to remind myself and tell everyone is that this is about you. This is about the patient. Ultimately, it's a team approach that focuses on what you need. So I think an important part of the discussion that you should have with your doctor when you see them is, what are the short-term needs that are affecting you? You have an immediate need because of pain, you have trouble carrying a particular activity, or we're talking about a long-term need. There's activities that you need to continue to do, a type of productivity, a type of activity that you enjoy with your kids or grandkids. And those needs, I think ultimately, along with the examination, along with the imaging that we obtain, will connect the dot to give you a proper diagnosis. So make sure when you see a doctor, you really try to figure out exactly what the diagnosis they're talking about. And if you have a really good diagnosis, it's very easy after that to develop a good plan, and that's what the treatment is. So again, I think a team approach and a patient-focused practice, I think, sets us apart, from other practices as well. A little bit about myself. Again, my name is Mohammad Al Sawaf. I had the pleasure of, transitioning through different countries and continents and states to get my medical education. I did my medical school in Jordan, the country, overseas, and then I came here, did a year at Mayo Clinic, did another year at the University of Minnesota, and then had the pleasure of doing the orthopedic residency at Wayne State University in Detroit, Michigan. And then I decided that was too cold, so I went across the country to Phoenix, where I did my shoulder and elbow fellowship at the Core Institute. Practiced there for a couple of years, and they decided it was too hot, so I came back somewhere in the middle. Since then, I've worked here at Pleasant Prairie and Kenosha for the past 8 years or so. I think we have a very successful practice, thankfully, and so hopefully we'll continue the journey along with all of you. Why did I choose to go with shoulder surgery? It's really a personal question, and when I went to medical school, when I went into orthopedics, I had no idea what shoulder and elbow surgery was. I think it really appealed to me that I can be specialized, but still wide-eyed approach to all the issues that affect the shoulder. Relatively to other areas in orthopedics, shoulder and elbow is a younger specialty. And so I appreciated that about it. I wanted to be on the frontier of what new innovations will come in that specialty. There's newer and newer appreciation for the special anatomy of the shoulder, and we will cover that a little bit. With the type of activity that we do in this day and age, there's a lot of office work, there's a lot of blue-collar work that really focus on the upper extremity, a lot of the manufacturing plant around here, that job, that work injuries, those focus a lot on the upper extremity. And as I mentioned, it's an expanding frontier, and I think it's really helpful. We'll talk a little bit about the advances. That's what we're talking about today, advancements in shoulder and elbow surgery. When I start with my description to a patient talking about the anatomy of the shoulder joint, I say it's a golf ball sitting on a tee, and that tee is sitting on its side. It's a big ball and a smaller socket, and it's really difficult to imagine that ball being stable and sitting where it's supposed to be if it didn't have a proper collection of muscles and ligaments and tendons keeping it in place. And that's what we will talk about in the next slide. The shoulder joint is not really one single joint. It's 4 joints that we all together call the shoulder joint. The big one that we know is the connection between the ball and socket area. The second one is the joint between the collarbone and the rest of the shoulder blade. The third joint, you don't see it here on this slide, between the collarbone and the sternum and the chest area. And the last joint is between the shoulder blade itself gliding on the chest wall. It makes for a really complex set of movements that are available to that joint. On top of these bones, you see a set of muscles that are called the rotator cuff. And it's called that because it's like a shirt cuff. It's a round group of muscles that have different muscle compartments, but they meet to make one tendon unit from the front to the back, and that's like a splay representation of these muscles together. On the image to the right, you see a front view and a back view of the shoulder, and as you can see, it's really all covered in muscles and tendons. And it is those tendons that keep that golf ball stable where it is supposed to be. And that's why you would appreciate why someone with a dislocation or rotator cuff tear will have a lot of trouble moving their shoulder about. That's a second representation of the rotator cuff to show you that these muscles and tendons, they work together. So there's a very strong collaboration between the front of the rotator cuff and the back of the rotator cuff. There is a strong collaboration between the top of the rotator cuff and the bottom of the rotator cuff. All these 4 tendons, they work together in collaboration with the deltoid muscle to make one smooth motion. Compared to other joints in the body, the shoulder is specialized in motion. It is the most, it is the joint of the body that has the most motion of any other joint. If you're talking about the knee, the hip, the ankle, the elbow, they're much more restricted either by the direction of the movement or the range of the movement. The shoulder has a lot of, almost a 360 range. And If you really have to have motion, you have to sacrifice stability. And that's why, compared to other joints, it's a relatively unstable joint. It's a lot more affected by dislocations, by ligament injuries, and such. It also is a sliding joint. It not only moves as a ball on a socket, there's a lot of sliding back and forth and top and bottom that can happen. And a lot of that sliding carries an important role in the way arthritis develops in the shoulder. It is rare to see arthritis in the shoulder joint being limited to the center. Usually that ball will glide and will create either arthritis more towards the back or more towards the top. It's rarely in the center. One of the things that also affect the shoulder, because it's such a small socket, if you lose any amount of bone in that area, whether it be arthritis or a fracture, you have a lot of more limited options to be able to fix it. So that's why it's really important to get a shoulder evaluated early on, to appreciate not just a close-term or a short-term plan, but a long-term strategic plan to make sure that it does not go beyond what can be fixed or reconstructed. As I mentioned earlier, in our area especially, and maybe everywhere in the world, there's a lot more demand on the shoulder that did not used to happen before. The type of work that is required is a lot more focused on the upper extremity. That's why this specialty came about. There's also a lot more recreational work that didn't happen before. Nobody knew what pickleball was, 20 years ago, and now it's one of the fastest growing sports in the US. I play it myself, and I can see how you can hurt yourself even though it's such a great sport. People still play tennis to their 70s. People, not a day goes on without asking about golf. People want to go back to golf, especially with the good weather that we're having. If you're talking about the younger patients, there's strong emphasis on sports, whether it be in school or at college level. You're talking about heavy weightlifting, gymnastics, baseball. And these small stresses can accumulate over time. You'll see patients who have injuries that happen from their weightlifting days, people who had injuries from their, chopping wood for 30 years in a row. And so ultimately, for you, the patient, when do you know that you need to be checked? How do you know when it's time to really be seen by a physician? The first thing that I'll talk about here is, do you have the symptoms? I'll run a little bit about the symptoms that are relevant if someone has a shoulder and elbow problem. I think it's important, a lot of people are anxious that if they visit the surgeon, it means they're going to be booked for a surgery the same day. I would really take a different mentality in knowing that knowledge is power. My best day is when I get to sit with you and educate as much as I can about what I know and what I don't know, and allow you to ask the proper questions, give you the proper handout, give you the time to think about the information. And if I did that, then I think I did my job. If you go to the physician asking for information about your body, I think that's the right mindset that you should do. Surgery is only one of the tools. We love the surgery, we love the outcomes that we do, but most of what I have, 90% of the things that we see, can be treated without surgical intervention. And it's really important to have a good doctor-patient relationship. A lot of times, even if you require surgery, coming to that doctor early on where you can understand what they do, understand their style, be able to voice your concerns, and have them tell you that you don't need surgery now, but you might need it in a couple of years, is a lot more comfortable to you to establish that care. So when the time comes for surgery, you're not nervous about a person you're meeting for the first time. So again, focus on the symptoms, try to know about your body, understand that there are a lot of options, and try to really develop that relationship with the physician. Shoulder pain is obviously the most common symptom to shoulder and elbow pain. And it can be very specific to a point, and it can be sharp or searing or knife-like or stabbing-like, but it can be very vague. The most common area that patient usually talk about is more in the side of the arm deltoid area. It can go towards the elbow. It usually goes towards the neck or towards the shoulder blade. And that's what we typically call an intrinsic shoulder pain. That's shoulder pain coming from arthritis in the joint, coming from a rotator cuff injury in the joint, but it can also be from somewhere else. One of the main things that I do on the first time I see a patient is to try and see if this shoulder pain is coming from somewhere else. There's about 5% of the patients that we see in an office who have pain coming from their neck. They will swear to you that it's in my shoulder, but the source is coming from the neck area. And it's our job to find that out and have them see the proper specialty, see the spine doctor. Some people can have an abdominal issue that refers to the shoulder area. They could have a heart problem that goes to the left shoulder. They could have some elbow issues that manifest that way. I've had patients with carpal tunnel in their wrist who presented to me the first time around with shoulder pain. And when the carpal tunnel was treated, that shoulder pain went away. So that first presentation to figure out the shoulder pain is really the most important thing. Along with the shoulder pain, there are quite a few things that can happen. People who have an injury can have a deformity. They can have swelling that happens immediately or after a period of time. They can have clicking with certain motions. They can have limited motion. They could have really bruising. And they also can have a lot of weakness. So I'll always be asking about pain. I'll ask about weakness. I'll ask about what motions were restricted for that particular patient. Just a handful of injuries, just to throw that out there for patients that, for injuries for the shoulder that we treat. We see collarbone fractures, very, very common. The clavicle is the most common long bone to be injured. Shoulder separation, very common sports injury especially for football players, soccer players that we see. You hear a lot about labrum tears or slap tears that can happen at the shoulder. Shoulder dislocation, I'm sure everyone has heard or seen someone with a shoulder dislocation, also a very common field injury. Rotator cuff tears, which we will talk about, and ultimately a lot of these injuries, once they happen for a while, they could have been ignored or maybe partially treated, they culminate in shoulder arthritis down the line. Some of these things may not really be an immediate injury, but it will present gradually with wear and tear. Part of that is just getting old, and we have a population that gets older with the advances in medicine and the way we take care of each other and the way we our culture wants to stay more active and independent as long as we can. And some of these things can be related to genetics. People have sometimes a genetic component that will make them more susceptible to have arthritis or certain types of rotator cuff tear. There's even special anatomy within the shoulder. If you have your special angles between the ball, between the socket, between the roof of the shoulder, and those angles you were born with can make you more likely to have one injury of the shoulder or another injury to the shoulder. Ultimately, one of the things that I look at and I talk to patients about is this last point here, muscle atrophy. When a muscle gets disconnected in the shoulder, when you have a tear, these muscles don't just float. They shrink because they're not really working, they're not functional, and it creates for an interesting discussion trying to figure out how to restore the function to that area. Before we talk about the advances and the exciting things I'm going to talk about, I think it's important for me and everybody to just take a moment and be down to earth and understand that there are things still about the shoulder that we don't know, and there are really limitations to what the present day science can give us. And it's part of the honesty that we promise you is that I tell you about something I don't know. And if something may not have a perfect result, that I will tell you about that as well. And with that behind us, we'll talk about the new and improved stuff in shoulder and elbow surgery. A lot of the stuff that I have for you is really a collection of looking through the last 3 to 4 years of medical literature that pertains to the shoulder and elbow. These are some of the premier sources that we look at when we're checking these surgeries. It's a well-established field. A lot of research is going on the topic. This is a bit of a busy slide. I don't really expect you to try and read and kind of understand everything here, but it's a reminder to me that everything we do is a work in progress. Just over the past 30 years, which is, about I was, a little kid at that time. A lot of the surgeries that we do for the shoulder and elbow has changed. People used to do a lot more open surgery at the time. There was a lot of salvage procedures being done. There was a lot of patients who were told just kind of live with it. And some of the procedures that we've developed in the early 2000s ended up being short-term surgeries that didn't have long-term success. But there were some great surgeries that we ended up continuing with and building upon. And you see here to the right, there's about almost 9 different procedures. A lot of these procedures have good short-term outcomes, good medium-term outcomes, but we don't know necessarily about the long-term outcomes because they haven't been available to us for such a long time. It just tells you There's a lot of technology, a lot of science, a lot of studies going on in this young field of shoulder and elbow. That's another busy slide also looking at the same, about how we try to put these procedures in buckets that really relates to the type of pain that you're having, to the type of weakness that you're having. Are you a patient who's younger or older? Are you someone who's more comfortable with a sedentary life, or someone who needs to be a laborer lifting 100-pound equipment all the time? Let's talk about, the first thing that I'll talk about is the advances in understanding shoulder and elbow diseases. Because it's a fresh specialty, because there is a lot of stuff that's going on, there's a lot of focus on basic science articles talking about the shoulder and elbow. And those advances have really helped us improve not only on the surgical approaches, but also on the non-surgical treatments, and I'll bring some examples of that. There's a lot of dedicated studies that talk about implant design and that talk about the long-term function for some of the surgeries that we will talk about. For example, I'll start going straight into trauma surgery. The way we fix bone fragments together around an implant when we do a fracture surgery for a patient has really changed a lot since I started in training. The way, even the simple way that seems simple to us about how you bring the sutures together, about how many sutures you use, about what special configuration you need to bring about, is something that has evolved every 2 to 3 years. And a lot of that has been down to long-term results being followed, and a lot of that follows what you're trying to check as far as micromotion. Is there some movement that still happens after a particular type of fixation? You want things to be as stable and strong, as good as it can be. Simple example, important results. Another question that did not really have a lot of good answers is when we saw rotator cuff tears. We couldn't tell a patient exactly if they had a particular type of tear, if they need surgery or not. Over the past 10 years or so, we've been able to delineate the need for rotator cuff surgery much better. We've been able to see that people who have injury on the more dominant side, who had a full thickness tear, were much more likely to have progression, which kind of makes sense. But we also didn't know how long a patient can wait. Can they wait till the end of the summer? Can they wait until next year if they have to remodel their house? Should they avoid weightlifting altogether while they're waiting? And for some of the partial tears, you actually can wait up to about 4 years before you need to be checked again, maybe for another MRI. As long as your pain, as long as your weakness, as long as these symptoms did not change, as long as you didn't get another injury. Those are answers we were able to provide that we didn't have before. So the simple message to some of these patients that if you have a degenerative small tear that may be partial, you can really wait and think about it. Sometimes that science allowed us to be a bit more forceful in recommending a surgery to the patient. We know that patients who had medium to large tear in their rotator cuff, who had symptoms when they came to see us and not just wanted to get something checked, or we were looking for something else and figured out that they have a tear as well, those patients are much more likely to have progression of those tears, and as such, we are more likely to recommend surgery early on for these injuries. There's a lot more understanding about what type of repair you can do. The early phases of a rotator cuff repair used to be what we call a single row repair. You had a single row of sutures repairing the tendon. As things progressed, we started moving into what we call a 2-row repair. And for the longest time, there used to be debates about single row versus double row. And up until recently, we honestly didn't have a clear idea. People used to do one or the other. And now we have a much better idea that there are special tears that a single row could be okay, but for certain tears, there's a definite long-term difference if you do a single row or double row. For my practice, with most of the tears that I see are medium to large tears in this population, a lot of the tears that we fix are usually double row fixation. And we have found that if you have a large tear, there's a good results early on in the first 1 to 2 years, but if you do only a single row, the results deteriorate between year 2 and 8. So that talks about some of the new understanding to what we do as a practice. There's been also a lot of focus on developing new surgical approaches. What does that mean? There's been a lot of transition from open surgery to minimally invasive surgery. And some of that has been established, like for example, rotator cuff repair surgery has been done arthroscopically for the past maybe 15, 20 years or so. But a lot of the other less known procedure, whether it be fractures or ligament tears, used to be straight open. I trained with it, just less than 10 years ago to be fully open, never done them arthroscopically in my fellowship training. But as you go into the practice, they're done almost 100% arthroscopically these days. The rotator cuff instrumentation, the instrumentation that we use during our surgery, has become more tissue friendly. The hardware that we use, and I'll come to talk about some of the implants that we use in our shoulder, has become better. And I think all of that together has come as a result of us recognizing that when you do a surgery, you're creating some injury to the tissue and you're trying to minimize the injury to that tissue. For example, this X-ray on the top is one of the ways we used to approach shoulder separation, was by creating a big incision on the top of the shoulder, putting a plate that goes on top of the collarbone, and then it glides under the roof of the shoulder, under the acromion. And that's a plate that then had to be removed about 3 months later. It was a good surgery for the right patient, but you can imagine how much dissection had to be done compared to the way we do it pretty much all the time now through arthroscopic incision with a small implant that just glides and connects these bones together. And the interesting thing is, when you test these in the lab, when you check the results of the arthroscopic surgery are more durable, they're stronger, it's a better technique, it works quite well for patients who have good bone. So we've transitioned really quite well into arthroscopic surgery for that particular injury. We were able to also move these implants along with that technique to be able to accommodate with stronger fixation and minimal scarring. Another surgery that really has changed quite a lot in how we achieve, there were a lot of non-repairable rotator cuff. That means a rotator cuff injury that has been present for quite some time, that the tissue that is available cannot really be fixed. And it was one of those vexing things that you didn't know what to do with. And one of the options that we can offer right now is to be able to borrow other tendons that are close by and reroute them into the area of the rotator cuff to do that job. There are quite a few surgeries that are called tendon transfers. This is, for example, one of them. This particular area talks about the back of the shoulder. If the back of the rotator cuff was really not available, completely torn, completely gone, you can borrow part of the trapezius muscle, the big muscle of the back, and route it with a graft into the shoulder, and we call that surgery arthroscopically assisted. It's done mainly through a arthroscopic mean, through small incisions, but you create just a little bigger incision over the muscle to harvest it and pass it into the shoulder. Great results. I had patients who were HVAC technicians needing to lift, AC units day in and day out. They could not do that when they did not have a rotator cuff. And once you do the transfer, allow them to have a strong muscle unit, they go through the proper rehab, they can go on without any restrictions. Again, a surgery that was not available without the proper basic science, without seeing a need and developing a new approach for this surgery. Some of the same tendon transfer, this is from the front of the shoulder. If the front rotator cuff is gone, we borrow a muscle called the latissimus dorsi in the front of the shoulder. Also a transfer that was not really available to us. The technique has been really honed over the past 5-7 years or so. And we're able to see their medium-term outcomes and make sure they work well. As you see here in this research, about 83% of these patients were able to go back to their previous level of activity. That's 4 out of 5 patients. That's really a great result for a muscle that was not present to begin with. Moving on, we talk about the new technology. I mean, orthopedics in general is one of the best specialties that have a great collaboration with engineers to bring about new technologies. And a lot of the processing power that we see in computers and imaging have allowed us to get information that we couldn't really use before and put it to good use. There's quite a few examples, and I'll show pictures of some of those, on how you take an MRI or a CT scan, you input it into a computer program, you're able to see a 3D representation, as you see in this slide, and you're able to think about the anatomy of the patient. You're able to appreciate the differences between patient A and patient B. You're able to match the right size implant. You're able to anticipate any complications in surgery or abnormal anatomy the patient may have. These information 10 years ago, you only found about them during the surgery. You had to be prepared for them, but you couldn't really, get ready for them or anticipate them ahead of time. For me, it's a great time to be in. You get to really interact with all of these new things. I have to update my software every couple of months to make sure that it's staying on the leading edge of what we can do. Some of the technology is not necessarily just, orthopedics. A lot of it is really collaboration with radiology, and we have a great musculoskeletal radiology team here at Frederick South. We have a great relationship with the musculoskeletal radiologists. Every week, honestly, there's about 2, 3, 4 phone calls that go back and forth, them asking me about a certain imaging they had. I had a phone call yesterday about a replacement that we requested some imaging. A lot of times I will call them because I see something they didn't appreciate on the read, and I want to make sure I'm seeing something right. We have really strong collaboration that helps us, get all the information that the patient needs. A lot of these changes have happened in the realm of CT scans and 3D and MRI scans. CT scans have become much better in high resolution without adding a lot of radiation to the patient. We have really improved a lot on the 3D reconstruction that we can get for a lot of these images, and a lot of patients who have seen me in the office will see the 3D representation of their shoulder, looking around from the front, from the back, appreciating the anatomy. For someone who had implants in their shoulder before, these implants used to cast a long shadow, pun intended, behind on the bone, and it was very difficult to appreciate the tissues behind the implants. And we have very good technology that can minimize the metal artifact that you can see. MRI has improved in how sensitive it can be. Right now we have a 3T MRI here that allows you to cut down the time to do the MRI by about half, or you can take a bit of a longer time and get it a lot more sensitive and clear if you want the best image that you can get. If a patient is claustrophobic, they can't really spend a lot of time in the scanner. You can cut the time of the scan and still get as good of an image as you used to get before. And with the images that you get, with the contrast studies that you get with an arthrogram, I think the information that we get is really unprecedented on how much you can dig down on the deep level. This is another example of the program that I use day in and day out, really planning for surgery. You get a CT scan with a 3D reconstruction. You get an exact shape of what the shoulder blade and what the ball of the shoulder looks like, and you can rotate it around. You can appreciate where the bone damage has happened, and you can put the implants that you're planning to implant in the patient. You can superimpose them on the skeleton. This one doesn't feel right. This one doesn't fix the problem exactly as intended. You can rotate it. You can get as much coverage, as much support to the bone as you can, and you can take that plan with you and execute it in the OR. Really unimaginable. This was not present on the day that I trained. It just was in infancy. It was not as accurate. Right now, it's difficult to imagine doing a surgery without having such technology available to us. It really helped to minimize the chance of orthopedic complications. Everybody comes out of the OR and they feel like they did a great surgery, but really digging down on your results and making sure that you get as good of a implant that matches the patient anatomy, I think does make the extra difference. This is an example of an even more complex imaging and technology and engineering that can be done. This particular patient, that's a patient of mine, had significant damage to their shoulder that was beyond what an off-the-shelf implant can do. So you get to send the CT to engineers who 3D print from the ground up a specific implant to them. That's the same implant that you get to put on their shoulder. You literally take it from the box and you put it on their bone and it fits it like a glove. Unimagined before. And that type of, for example, damage was so difficult to tackle before. You couldn't really give them a good option, or the options that you were able to provide to such a patient left them with significant restrictions because we didn't have enough bone available to us to work with. Now you're able to build up some of that bone loss with metal to support the shoulder replacement that we're doing. Some of the new technology that actually is developing now, we had a chance to kind of work in the lab with these instruments recently, is what we call mixed reality. You take some of the plans that we've done before, and not only you have them printed on a piece of paper in front of you, but you've seen the Apple goggles and stuff that looks like it. You're able to have that plan superimposed on the anatomy of the patient as you're working in the OR. If you have plans to put a specific drill or cut the bone in a specific plane, with the right trackers that you have, you're able to line things up to match what you can do. A lot of this stuff has kind of been done to a degree in hip and knee surgery before, but for the shoulder, it's such a small exposure area, it's really groundbreaking. We don't know how much this will improve our results, but it's really exciting just to be able to have that skill and that tool available to you. This can be used for shoulder replacements, and as I say here in the last bullet point, it can be used for shoulder instability. A lot of times when a patient has a shoulder dislocation, they knock a piece of the bone out of the joint, and that piece of bone, a lot of times when they come to see us, has withered and disappeared away. And you have to rebuild that socket for a 20, 25-year-old patient who needs that shoulder to function with them for 50, 60, 70 years. And we're able to plan some of these surgeries ahead of time, get the bone graft to the right size, and line it exactly with the help of mixed reality goggles to line it up exactly on the surface of the joint where you planned to put it before. New implants. One of the most exciting things is we get new gizmos to work with. So the picture on top shows you old shoulder replacements that were from about 1950, 1940s. I mean, you had to replace about half the humerus bone, the way it used to be fixed to the bone, if you can see up here, like through wires that go through, and they had significant failure rate, about 50%. But that was the best available at the time. We see that, and we are really fortunate and happy where we are, but if it wasn't for these pioneers and early scientists and physicians who took it upon themselves to sit and design and fix things, it would be difficult to be where we are now. Nonetheless, we are at a point where we can offer patients what we call stemless implants, bone-preserving implants, implants that take the minimal amount of bone from the joint and replace it with just the right amount of the implant to restore the same anatomy, to hopefully get a better function. And it actually allowed us to have surgery that is less complicated. You don't have to worry about as much if a patient had previous injury or a deformity to their bone. If this patient requires a revision or a second surgery in the future, the next surgeon will have a lot more real estate and bone to work with instead of coming in and finding that they have nothing available for them to work with. So it makes for an easier revision surgery, implants that are a lot more friendly to bone, and because we were able to improve the fixation and how it fits to the joint, we're able to reach longer survival periods. These are arthroscopic implants. They kind of look big here, but in reality, they're really kind of small, 3-4 millimeters in diameter. The early anchors used to be all metal anchors that you can see 30 years into the future, they're still going to be there. A lot of the anchors that we use now are completely absorbable within about 5 years. So if someone had to have surgery later on, I go in without having to worry about all the anchors that are going to be in my way. A lot of these anchors have channels in them that allow bone to grow in, allows more blood flow to grow in. Some of the newer implants are even completely made of suture, so you're able to take such minimal amounts of bone to be able to place the anchor where you want it to be. It's a lot evolution for a simple thing as a screw, that you use in surgery that has evolved again to serve different functions that you need. As such, healing rates have become better, the amount of bone you have to take out is better, the amount of immobilization has been shorter. This is a recent development also in implants for patients who did not have a good rotator cuff to work with, but they're not really ready to have a shoulder replacement. A lot of times they needed some surgery that can carry them halfway into when they require surgery. And one of the options that we've utilized is a balloon spacer that allows to create the proper amount of space between the ball of the shoulder and the roof of the shoulder. One of the procedures, that I listed for you, a lot of the options that we have good short-term, good medium-term, we're waiting for long-term data, but it has worked quite well for pain relief. These implants were not available, 3 years ago. Once we're done with all of the above, these are the big, really items, right? You're doing big implants, big cuts. There's a lot more involvement also on the healing fronts. The science on these is not necessarily as clear, and you'll see me here say that there's mixed quality data. I think this part of orthopedics in general, and especially within the shoulder and elbow, is still early on. I have used some of these off and on. There's more, substances that we're still excited about, but we're kind of still careful to follow. So if you come to talk to me, you might find me discouraging you from using a certain biologic, encouraging you to use a certain biologic, or telling you that we really don't know at this time. One example that I will talk about here is platelet-rich plasma, which involves taking some of your own blood and putting it in a centrifuge, kind of spinning it around to take what we call the ultrafiltrate of that blood sample, which has the highest concentration of stem cells. People used to use it for everything, but within shoulder and elbow, we have found that there are good results if someone has a frozen shoulder. It has good results in patients who have early arthritis, but it didn't really have great results when you used it for rotator cuff repair. So, like I said, the jury's out on some of these things, but it's an indication where the entire field of medicine is moving towards. We're focusing a lot on healing, and some of that healing can come straight from your own body. Within surgery itself, there has been a lot of evolution on the grafts that we use as well. If a patient did not really have proper bone grafts available to them, the classic graft that we used to take was from their hip area or spine area. And we've had much more improvement in the processing of allograft, of cadaver bone, and some of the skin grafts and the collagen grafts that we have, that we can use them without requiring a harvest from another area of the patient. Depending on how much support I need, it's quite frequent that I would use what we call a dermal allograft. It's a thicker piece of tissue, quite stout and strong, or sometimes a thinner collagen graft that serves a support role and just enhances a faster healing. Both of those are really in wide use, have good results when they're used for the right patient. Sometimes, like I mentioned, the biologics can come from your own body. This is a procedure that we do sometimes for the biceps tendon, where instead of, if someone has a lot of biceps damage and their biceps tendon is not really doing great, you take a portion of the biceps tendon and you use it as a graft to replace a portion of the rotator cuff. These are techniques, the biceps tendon has always been there, but these are techniques that have been really developed quite recently to be able to utilize the local tissue as much as you can. And it has quite good function with local tissue. Stem cells brings a lot of questions from patients. People search through Google and that's the first thing that usually pops up. And strictly stem cells, something that comes from the fetal or the umbilical cord, has not really had convincing evidence within the shoulder yet. I am sure in the future we will have much better concentration and targeting tools to allow these cells to proliferate and get incorporated into the tissue. But at this time, I don't think we have a good standard protocol for using these in shoulder surgery. And as such, a lot of times there's not even insurance available to cover these, even if the patient insists they want such procedures done. Let's try to tie it all together. I've talked about a lot of innovations in the basic science, in the surgical approaches, in the implants that we use, in the imaging studies that we use. And I think it really ties down to us being able to offer quite a wide range of treatments depending on where the patient comes in. If the patient comes through the door today with a rotator cuff tear, depending on what the imaging shows, depending on the characteristics that we talked about with the natural history of such a tear, their treatment could be absolutely 100% non-surgical. combination of therapy, possible injection, activity modification, and observation. It may require a repair. That repair, if you have poor tissue, may require a graft to support the fixation. If they don't have a rotator cuff at all, then we might have to transfer a tendon. Or if they really don't have a lot of tissue or a lot of demand, you might just use a balloon to support that area. Same thing goes for labrum tears. You go through multiple stages of how you approach the problem, depending on the imaging, the examination, and what the patient requires at that time. We see a lot of patients with biceps disease. A lot of those can be treated with just an ultrasound-guided injection in the office. Sometimes you have to release the biceps. You can incorporate it into other tissue. You can fix it. A lot of, different things that we do. And ultimately, the most common thing that I kind of do in my practice is for patients who have arthritis. We do early injections for those. We do special rehab. There are special surgeries that do preservation, so you do not have to replace the joint. But ultimately, like I discussed, you can resurface the joint. You can do bone preserving or go for the full replacement if they have really weak bone. That requires extra support. Part of the specialty that I do is shoulder and elbow surgery. Even though I haven't really discussed a lot about the elbow today, I'd say about maybe 20% to 30% of the patients that we see come with elbow injuries. A lot of that can be a tennis elbow, can be a golfer's elbow, and we have a really quite comprehensive protocol for what the treatment would be for those types of situations. As I said, we see a lot of patients with nerve entrapment, and it's really important to have the right examination and the diagnosis to tell the patient how to brace, how to protect that nerve, and in case it requires to be released or moved into a safer area, how that can be done. Tendon injuries. This is the summer season. We see quite a few patients with biceps tears at the level of the elbow, triceps tears. These are injuries that are supposed to be treated quite expediently within about 2 to 3 weeks to try and get the tendon where it's supposed to be. With the right, timing and the right implants, you can achieve really great results and allow patients to return to function without any restrictions. Elbow arthritis is one of those things that we continue to see, even though it is not as common as other areas. We have elbow replacements that are available and durable. We have resurfacing, grafting procedures. We actually have open, complete, cleanup procedures to realign elbow replacements. To align elbow arthritis to back where it needs to be. Quite a few options for those patients as well. Take-home message, and I hope this provided simple information without a lot of confusion, is that advanced shoulder care is available here. We're really happy to help you. We have a great team, both on the clinic side and in the operating room, that can take care of you quite well. I am really proud to say that specialist care allows you to have the latest data and latest information and latest technology and innovations available. Early diagnosis is critical to recovery. Establish that relationship with your doctor. A lot of the injuries and the diseases and the pathology that we see can and should be treated non-surgically. And it's quite helpful to see a patient come to see us and them going through the rehab that they need to do and coming to see me with 100% resolution. And I tell them I really didn't do much. I maybe helped to guide, but I'm glad that I didn't have to cut you open, and I'm glad that you're able to go back and be as active as you can be. But for the right patient, surgery will help to minimize pain and give you a quicker recovery. And so have a good discussion with your doctor regarding treatment options. And I'm really more than happy to take any questions that you might have. Go ahead.
I've had both shoulders repaired.
Yes.
And I need a repair on the right.
Yes.
My biggest concern is that shoulder surgery is the most painful thing I've ever gone through.
Mm-hmm.
And is there anything new in post-operative pain relief or interscaling block? I had a bad experience with the interscaling.
Yeah. We have quite...
Can you please repeat the question for the audience?
Yeah, I'll repeat that question. So one lady, the audience indicates that she had both shoulders repaired before, and my understanding is that she was told that she requires another repair for one of them.
I don't know. I'm coming to see you in a couple weeks.
Very good. And the concern is that she had a lot of pain. Thank you, thank you. And the concern is that she had a lot of pain with the previous surgeries, and she wants to know if pain after surgery is better managed these days.
I don't do narcotics.
Very good. And she makes a good point of saying that she really doesn't like to do narcotics. Pain has become quite often synonymous with shoulder surgery. And it really took quite a lot of work and improvement in technique and to change that perception. Some of the surgeries can maybe still lead to some pain, but some of the techniques that we use, some of the smaller implants, there are different types of blocks, some blocks that last a bit longer. There are different multimodal, which means multiple staggered elements of pain relief that we use these days that I think, compared to my early practice, we see a lot less concern on much more predictable pain relief after. It would not be the truth to say that there's no pain at all. There is a surgery and there's a swelling and there's recovery that comes along with it. But I do believe it has really come a long way from where we were before.
Okay.
Yeah.
So once that block goes off.
I understand completely what you're saying.
Yeah.
I could help her with that question.
You can go
I
ahead.
just had the surgery done, and I took a pain pill for 2 days, and I didn't think I needed them. But
Yeah.
I had no pain at all.
So it's quite to have good results as well. Any other patients who have questions, any other, people in the audience who have other questions?
I got it.
Please go ahead.
I had both shoulders replaced.
Yes.
At this one, I had a reverse done.
Yes,
They took the rotator cuff out.
Yes.
Lasted less than a year, but before they could do the surgery, the screws were coming out.
Yes.
And they keyholed where they were in. Now it's just, that's as high as I can lift my arm. This one, but I can't lift it. Can that be replaced? The bone is messed up or keyhole.
so he's asking a good question. He's saying he had a shoulder replacement before, and it sounds what you're describing to me, that there's been some loosening to the implant.
It did when they did the reverse, they took the rotator cuff out.
Yes,
And the bone, and I had pain in it, I had it x-rayed, and the screws were coming out.
yeah, so some loosening to the
But it was 2
implant.
months later that I finally got the surgery,
Yes,
but they couldn't put it back the way it was.
Yeah.
It worked fine with the reverse, it worked for me. But now I can't, I can only lift the arm.
and he's saying if I'm explaining to the audience, he's saying that he's having trouble with elevation of the shoulder, with raising the shoulder up. A quick answer is really difficult to give without looking at imaging and examining you.
No, I'll make an appointment.
But I will tell you, there's quite often we're able to look at some loose implants and we're able to do a revision surgery to address it. A lot of the procedures that we do, and a lot of things that I do are not necessarily first-time surgeries. They may have had a rotator cuff done 15 years ago and they had great results, but they had another injury and it failed, and you have to really deal with the implants that were there and the new tear. Quite a few patients had replacements, and the longevity of the replacement varies depending on the generation. And if it loosens for whatever reason, there is quite a separate evaluation to evaluate for somebody who needs a revision surgery. I'm more than happy to take a look at that. All right. Well, I honestly am honored for all of you being here. I hope this was useful. And I hope we can provide good care for you and everyone in Kenosha and Pleasant Prairie for years to come. Have a good rest of the day. Okay. Thank you.